My name's Dr. Kuechle, and today we're going to be talking about the hip exam. So the first step of the hip exam is inspection. So we'll have you lay down here. So the first things you want to look for is any signs of any bruising, deformities. You want to look to see if there's previous scars from previous surgeries. You want to see if there's any change in the leg lengths, to see if both legs are the same length equally, to see if there's a change in the position of the hips. And patients who have hip fractures, you'll see the legs will be more externally rotated. If there's other deformities, you'll see change when you compare one leg to the other side. Next, we move on to palpation. The areas you want to palpate include the anterior superior iliac spine here, where the insertion of a number of muscle groups are. That can be a source of and location of pain. You want to feel the area of the greater trochanter, where patients with iliotibial band syndrome or trochanteric bursitis will have pain. More posteriorly, at the ischium is where the insertion of the hamstrings tendons are, and can be an area to assess as well. You want to palpate for the femoral pulse in this area. Make sure that they have an adequate pulse as well. Next is range of motion. So we'll have her bring her leg up as far as she can to assess the range of motion and flexion, and then extension. Abduction should be about 40 to 45 degrees, adduction 20 to 30 degrees. In flexion, you'll assess internal rotation and external rotation, about 45 degrees in either direction. Next, we'll do special maneuvers. One is a flexion, adduction, internal rotation maneuver, where you're assessing for internal impingement of the hip, where the femur rubs on the acetabulum, can allow you to understand about labral pathology. Intra-articular pathology you can identify by allowing the patient to extend the leg, flex the leg up to here to about 30 degrees in resisted flexion, and can cause pain in the groin. That's called the Stimson maneuver. Also, to assess for hip flexion deformity, called the Thomas test, the patient will bring both of her legs up to her chest, hold the one leg with her arms, and then extend the leg at the hip. If the patient has a flexion contracture, they won't be able to bring the leg fully straight onto the bed, and there will be some tilt of the pelvis in that plane. Also important in any hip exam would be to see the patient stand and walk. So we'll do that. When the patient stands, you'll look to see, again, the leg lengths, evaluate for any tilt in the pelvis itself. You can ask the patient to stand on one leg to see if there's, again, loss of the ability to control the pelvis or stand. Then ask the patient to walk. Trendelenburg gait, due to abductor insufficiency, you would see the pelvic the pelvis tilt when she would walk. So again, today we discussed the important parts of the hip exam, including inspection, palpation, range of motion, and other special maneuvers.